And next talk is by Dr. Manju Abraham, Professor and Head of the Department, Government Medical College, Ernakulam, about picking them early and right, screening protocols and management of risk factors.
Thank you, Dr. Danya. We move on to a less stressful topic. Nonetheless, it's very important. The risk factors and screening protocols of diabetic retinopathy. So the risk factors may be grouped as modifiable and non-modifiable. The non-modifiable are the duration of the disease, age of patient, and genetics. Modifiable are the blood glucose levels, the blood pressure, serum lipid levels, microalbuminuria, and others like pregnancy, puberty, and anti-diabetic drugs. So we know that the retinopathy prevalence have come down now with a better control of our modifiable risk factors. Now let's consider each one of them. Two landmark clinical trials, the DCCT and the UK studies showed that intensive glycemic control reduces the risk of development and progression of DR. It is noted that a 1% decrease in HbA1c can reduce retinopathy development by 40%. And an early intensive control has benefits that last for up to 10 to 20 years, and we call it the metabolic memory. So it's it's recommended to keep the HbA1c levels less than 7, and earlier it is achieved, the better. Now, the Wisconsin epidemiological study showed that in type 1 patients, diastolic BP is a predictor to the progression of retinopathy. And the UK studies and the Euclid studies showed that every 10 millimeter increase in systolic BP can cause a 10% increased risk of early DR. And the study also showed that ACE inhibitors and beta blockers reduce the risk of DR. So our target BP should be less than 140/80. Now, what about dyslipidemia? The ETDRS showed a twofold increased risk of heart exudates when the cholesterol levels were more than 200. The beneficial effects of fenofibrate was seen in the field and the ACCORD studies, where there was a reduction in the DR progression as well as a need for laser photocoagulation. So it's ideal that you keep the cholesterols less than 200, triglycerides less than 150, and LDLs less than 70 in a high-risk patient. Now, coming to renal disease, in a prospective study done in type 1 patients, the risk of PDR increased from 7% to 24% after 4 years of onset of microalbuminuria. And the study also showed that gross proteinuria at baseline is associated with a 95% increased risk of DME. A decreased GFR as well as an increased urine albumin creatinine ratio significantly correlated with diabetic retinopathy prevalence. And if you see that in a previously stable retinopathy patient, a rapid progression is noted, the patient definitely needs a renal evaluation. And we also see that retinopathy remains stable in patients who are undergoing dialysis or who have already had a renal transplant. Now, what about diabetic medications? The DCCT showed that in the first 2 years after initiation of an intensive insulin therapy, the retinopathy can worsen transiently. So these people require careful monitoring every 3 months for the first 6 to 12 months. And you can even consider PRP before starting an intensive insulin therapy if the retinopathy is severe NPDR or early PDR. Now, the glitazones also increase the incidence of DME by 2 to 6-fold. These patients also require an adequate follow-up. Now, what about pregnancy? Retinopathy can rapidly progress during the second trimester. The effect may be transient. Women with the poorest glycemic control at baseline and those needing the greatest reduction in HbA1c in the first trimester are at higher risk of retinopathy progression. So it may be appropriate to perform a PRP before conception in severe NPDR patients to prevent further progression. Now, others like a hemoglobin less than 12 is associated with a twofold increase. A high BMI is also associated with a severe diabetic retinopathy. Now, the non-modifiable risk factors, we know the duration is the most important. The Los Angeles Latino studies found that each year of diabetes is associated with a 8% increased risk of retinopathy, and men are at an increased risk. Now, the second part of the talk is on retinopathy screening guidelines in India. The AIOS, Diabetic Retinopathy Task Force, and the VRSI have initiated measures to improve the screening in India so as to identify sight-threatening retinopathy early and to treat it promptly to prevent blindness. At present, there are about 3 million people who are at immediate risk of visual loss due to sight-threatening retinopathy. We have a high prevalence of undiagnosed diabetes in India, so we cannot restrict our screening to the known diabetic patients alone. So what AIOS have recommended is, though it is made appear not practical, all people with known diabetes on treatment or a single record of RBS more than 200 or an HbA1c more than 6.5 or a gestational diabetic, when first seen by a medical professional, should be advised a retinopathy screening. And the Government of India has also introduced a non-communicable disease register where the data of all diabetic patients should be entered, and these patients should be called for periodic screening. Now, how do we screen these patients? We have a community-based screening where screening should be done to all diabetic patients who attend the NCD clinics at the PHCs. We can do opportunity screening at the physician's clinic or the diabetology clinic, which appears to be the first point of contact for the patient. There are community outreach programs where door-to-door screening can be done to identify retinopathy patients. You can conduct exclusive retinopathy camps, and also you can screen at primary vision care centers. Hospital-based screening means diabetic patients that are seen at other departments are referred to the ophthalmologist. Now, the most practical way is a fundus photography by a trained technician using a non-mydriatic camera that gives you a wide field and which gives you high resolution images. All the captured photos are transferred to the base hospital. Now, if the technician can identify retinopathy, those images alone are sent to the base hospital. Now, if the technician is more confident and competent to grade the retinopathy, cases that are identified as more than mild NPDR are sent to the hospital. There, the ophthalmologist sees these images. A report is sent back to the NCD clinic or the diabetic clinic, and patients with sight-threatening retinopathy are asked to report to the main hospital. And the ophthalmologist should also see at least 10% of the normal images just to cross-check. Now, if the quality of the picture is poor, it may be due to cataract or a small pupil. Those people should also be sent to the base hospital. Now, when do you screen them? A type 1 requires screening within 5 years of onset of diabetes. Type 2 at the time of diabetes diagnosis and then annually. Gestational diabetes does not require examination. A patient with a pre-existing type 1 or type 2 planning to conceive needs an eye examination prior to conception and should be monitored at least once every trimester or more if there is, depending on the degree of retinopathy. Now, the follow-up guidelines are no DR or a mild NPDR every year, moderate NPDR 6 months, severe every 3 months, PDR with no high-risk characteristics every 2 months, a center involving diabetic maculopathy with good vision every month, a non-center involving with very good vision or every 2 or 3 months. Now, if seen by an optometrist, a patient with severe NPDR, PDR or a diabetic maculopathy should be immediately referred to the ophthalmologist. Now, to sum it all up, the ophthalmologist should ensure a timely detection of STDR by a periodic screening. A prompt treatment should be initiated to prevent blindness. You educate the diabetic patients and create a public awareness on this blinding condition and refer the patient to the physician for better control of the systemic risk factors and other complications of diabetes. Thank you.